Hello, Copenhagen is back.
Hi, Olaf.
So you
Hi,
heard
Lars.
already the team. Hi again. And we will immediately go to the introduction of the patient of the case. So Tina will tell us.
I will. The next case we would like to share with you is an ASD closure. The patient is a 43-year-old woman. She does not suffer from symptoms, but ASD was diagnosed at a routine examination prior to signing an insurance. The physical findings are 2 to 3 out of 6 systolic ejection murmur and fixed split second heart sound. Pre-tests have shown normal lung function, ECG with sinus rhythm, echo has shown ASD2 and mild dilation of right heart. Chest X-ray shows borderline heart size and MRI shows a shunt ratio of 2. So now we intend to show a closure with Occlutech Figulla Flex 2 ASD occluder.
Thank you. We will start. We are not doing a right heart catheterization in the sense of doing a Swan Ganz. We had the MRI and we also have the echo showing right heart dilatation, and the shunt was 2 in MRI. So Lars, what do you say? Is MRI a good thing to do a shunting in ASD?
I think without doubt, it's probably the most reliable way to measure shunt, more reliable than with the old-fashioned using saturations. And I think you have very accurate measurements in the pulmonary arteries and in the aorta. So I think yes, it's more, of course, a bit more costly to do it, but it's probably the most reliable way to do it.
What we don't have, because she doesn't have a tricuspid regurgitation, is the pressure in the pulmonary artery. In rare occasions there could be a surprise, so it maybe is safer to just enter one time the pulmonary artery and to get a pressure there. This is what we're going to do now. We use a multi-purpose catheter and go up. I'm already there. There's coming the catheter, but we want to go there in the pulmonary. Oh, there's another picture. You cannot see the X-ray?
No, the fluoroscopy, please.
So we just entered here the fluoroscopy. We see we entered with a multi-purpose in the pulmonary artery. Take one pressure to demonstrate it.
So let's see the hemodynamics, please.
So it's rather low. So there's no pulmonary hypertension, so whatever. Yeah. So we excluded that. Let's go to the other side. She did had a try of occlusion before, and there was turned out to be difficult to enter the pulmonary. Can I have the wire again? To enter the pulmonary vein. Therefore, we will be now surprised to see. We will what will happen.
So what wire are you using, Olaf?
It's a multi-purpose, and you see it's
and the guide wire.
Oh, I take the multi-purpose, take it on that side, try to take it up the other way, and probably in the that's the right one. So it's not easy, like we know, for some reason, which is not really understandable. Yeah. That's possibly. Can you see the?
Yeah, we see the
eyes image. This is possibly the left atrial appendage.
That's the appendage. I would come back more towards the spine and torque more clockwise. Come back more. Yeah.
I agree.
No, come back more.
I agree.
More.
Yeah. We do it. It turns around fully then. So we must be very cautious. Last time she had a little hemothesis. It looks like this needs to point further up. And this looks good. So we size it with a balloon. First we took now the Amplatzer super stiff, 6 centimeter J wire at the end, floppy, to insert it very careful in the lung vein. Here. Patient is under GI and we have eyes, and maybe we take the time then in a minute to show a little bit more about the eyes. Oh,
I'll take you, Olaf.
Yeah, thank you. So Niels, can you show us a little bit around why we have the wire now?
Yeah, here you see our probe is in the right atrium, and we are looking across the atrial septum. And in the bottom there, we see not the pulmonary veins, but the left atrial appendage, and the guide wire is pointing in that direction. And that explains why it was easy to get into the left atrial appendage. When we do these procedures, we find that it's necessary also to make sure not only that there's no other additional defects in the atrial septum, but that there's not something like a sinus venosus ASD. And for that reason, we will go up in the superior vena cava and go up to the level of the pulmonary artery. That's what you see here. The round structure in the middle is the pulmonary artery. The catheter is in the superior vena cava. And close to the probe, you see the left atrium. And in this area, where I will... this area up here is where you would have the sinus venosus ASD, and we always go up here and just exclude that was the case, because then we wouldn't have helped the patient by closing the secundum ASD.
So how large is the ASD, Niels?
We have just sized the ASD without a balloon to be about 18 millimeters in the largest diameter, and I don't think this is a round ASD.
So we decided to have a balloon sizing. That's always a question to have or not to have, but we will do it with a stop flow method and have a balloon sizing. So
can we see picture-in-picture fluoro and eyes, please? Thank you.
Sure. Can we see a picture, fluoro eyes?
Yeah, we see it.
We have it. Very careful, only very gentle we do it.
Turn the color
air must
Doppler
go
on.
out. I aspirate a little bit.
Color Doppler.
Can you see it?
Yeah.
There's still a little flow. This looks quite okay already. Maybe put a little like that. And then we take a picture and use both. Okay.
Can you get better view with
open?
eyes profiling the balloon better than this with the structures, a short axis and a long axis view, please?
Yeah.
With eyes.
Yeah, we have the balloon still open.
Yeah, here we have this is the long axis. You see the wire in the middle, and you won't get the actual short axis through the septum, because that would be a very peculiar position. So what you can do is that you scan across the balloon, as I do here. So here's one side of the balloon, and I come across it, and as I scan across, I see that it's a small defect. Now the balloon is in the left atrium. Now it's coming back into position. I continue to scan across.
Neil, can you do
and
me
I
a
think there's
favor?
A small leak.
Not more.
Yeah.
What kind of
What do you
eyes
want?
catheter is this? Is this the AcuNav?
No, this is the ViewFlex.
Ah.
So it depends in the superior and anterior and posterior only, but you can still get short axis. But then it sees. So see here. So I'll just move the catheter a bit. So I scanned across, and I think there was a small leak. So and I now get a different position to view the balloon here. I'm just struggling a bit here. Oops! Now it fell out of the liver here into the liver.
Looks like there's a ridge to the aorta.
Yeah. So here's the short axis view of the aorta. So this is the other direction, and here I will just put color on again and see if there's a leak next to the aorta. And there is. So there is a small
leak. So we have to
leak.
get it larger. Oh, then it's really large, huh? It's a 30?
Yeah.
Is everything fine with her?
And
So
I think we saw that leak when we were now it's the short axis view of the aorta. So this is what we call the short axis view of the septum.
it's getting better.
When we were scanning in long axis, I think I saw that by just scanning across. Then when you came close to the aorta, there was flow past the balloon, so we could already see that there wasn't a complete seal.
She has some pain, or?
But just to understand this picture, we have the aorta to the right
So shall we do it again?
and the floor of the right atrium to the left. Yeah.
Can you take the view where you saw the shunt, and then we balloon it, and there
Yeah.
we measure then also the size of the balloon, that we don't keep the balloon all the time open?
Yeah. Hang on. Oops.
Okay. Are you ready?
No, I'm just not completely ready. So yeah, I'm ready.
From here, from the...
There's still a shunt.
There's still a shunt. But then it's very large. It's amazingly large.
But maybe there's an additional defect that...
Ziad, can I make a
Do you
suggestion?
think
Sri
we are not
Raghavan
to
from
the right
Vejlstrup.
defect?
This is typically one of the patients. I think what we have done is entered through a patent foramen or valley, and we are trying to stretch with a balloon, and the other defect is not the defect where we entered. And we have an additional defect, which is the main defect that we need to close. Because if you look at some of the pictures, you have different planes where you're still able to stretch the device. You're having a waist on the balloon, but you're still having a flow coming through from the left atrium to the right atrium. So I think we're missing the defect. We're going through a different defect. I mean, the PFO is where we have gone in because he had a difficulty maneuvering his catheters, which shouldn't happen in a large defect.
Okay. Anybody on the panel have any comments about
So
the
just that
images?
I get the point. That I understand.
So his point, he
Chest
thinks
pain?
that there are two holes in this patient, a PFO and a secundum ASD.
Yeah.
And you're caught in a small hole with a guide wire.
Yes.
Yeah. So shall we recross? What is the suggestion?
The suggestion I personally would say, we need better images with echo to show us what the septum and the defects, whether there's one defect or two defects.
You're right.
Yeah.
You can leave the
we will,
wire in
just
without the balloon and then re-image the whole thing.
Yeah.
Yeah.
So what I'll do is
We
I'll
do
go
that.
back to we'll go back to the long axis.
Shielding.
I think it's a good suggestion. Can we
Actually,
hold?
I think a 2
So we need to get in the
ASD
throughput.
is not PFO and ASD. 2 ASD defect. And
Yeah.
anterior is larger than posterior inferior.
Get it up.
Okay.
So you need to show
It's
me some
better?
fluoro. We need to have the catheter in too.
Give me the sheath. Okay. She's very sensitive to the wire, really.
Yeah. Yeah.
Yeah. I would say I take the wire even out. It is not too difficult to enter it. And then you have a free view of what's there.
Yeah, actually, from this view, you can nicely see the anterior defect is larger. Your wire across is a posterior inferior small defect.
Right. I agree. We see it now nicely.
Yeah, I agree.
So let's try if we can go more anterior and enter the other defect. So give me back the multi-purpose. Oh, that's interesting. We were not aware this would be the case.
I have
And it's
one
not
more
completely
question for the
obvious when you
panel.
look at the echo P.
Especially when you close ASDs in older patients, what is the threshold for doing a coronary angiogram before putting in an ASD device, especially to look at the coronaries, as well as not just in the context of coronary artery disease, but also the course of the right coronary artery because of the disc deployment in larger defects?
Same defect.
Do you think so? Oh yeah, that's the same defect.
So, Olaf, what do you think about the coronary artery?
For the
and
panel or for us?
We'll answer this
What
question
was the
while you guys
question?
are
Repeat,
working.
please.
Olaf and Lars, you work will answer these questions. Tom, do you assist the coronary arteries routinely in your adult patients when you close their defects, or you don't?
I would.
How's it with this one?
So this is a 40-year-old woman.
I would. Same small hole.
I would just assess what her coronary risk factors are, and then go from there. If there were any issues of angina or other questions, you know, the typical coronary workup, but not angiography at the time of ASD closure. And as far as the right coronary compression with an ASD device, I've never heard of that. You're miles away, different planes.
I think this is...
Eric, you're there, so why don't you make a comment?
I just wanted to ask a question about the case,
the
actually.
view with the aorta is the best.
Before you ask a question, can you comment on the idea?
Yeah, sure. So our practice has been for the last several years. In patients over 40 who have multiple risk factors, we'll look at their coronary. So if I have a 45-year-old who smokes a pack and a half of cigarettes a day, they have exercise intolerance, we look at their coronaries. People under 40 who don't have risk factors, I don't think it's relevant.
Over 40 with no risk factors?
You know, I think it's on an individual basis. If you're 55 and you're really clean, you know, we might consider leaving it. But generally speaking, and the issue came, the reason why we started doing that is we had an erosion, and one of our surgeons the patient had to go to the operating room, and one of our surgeons was very unhappy that we're not assessing patients with ASDs like they would for an elective mitral valve repair.
Why again?
So if they had someone who's 45 with elective mitral valve repair, they would have the coronaries done before they operate. Okay. And they wanted the same standard for us.
Okay, Eric, just 1 second. So we're going to go back to Olaf and Lars. That's a good view now, and clearly it looks like that you are through the large anterior superior defect.
Yeah. That was also our impression, that we hear through, at least there where there's no aortic rim in that defect where we had the shunt, that we are through the defect which is close to the aorta.
That's right. That's right.
Oh.
Eric, you had a question. Go ahead.
I just wanted to make a comment for multiple defects that very often it's helpful when you have multiple defects is once you've crossed through a defect, you've blown up the balloon and there's color around it, just leave that balloon there and inflate it and go for the secondary defect with that balloon inflated. It avoids this repetitive thing of crossing through the same hole over and over again. Sometimes it just actually saves time.
Yeah, we agree. Yeah, that's exactly
Can you see if we are in the lung vein?
And you know, there's about 7% of patients that will actually require two devices that are remote, and we do the same thing, so we don't keep crossing the same defect. We blow the balloon up and go from another side.
Lung vein thing again. Is this the left atrial appendage?
Let's have a look. No, I don't see in the left atrial appendage.
My question regarding this case is that if it is difficult to enter the left superior pulmonary vein for some reasons, technically, should we insist on entering the left superior pulmonary vein? Why not just go into the right superior pulmonary vein and finish the job?
We don't insist on going to the left pulmonary vein. I mean, it's up to him. We need to enter the left atrium. You can either put it in the left lower pulmonary vein or the right upper pulmonary vein, wherever you want, as long as you are in the LSI. Absolutely.
But we decided to go in the lung vein again.
Yeah, I think
interestingly, as soon as we enter the lung vein, it gives this impression again
that you're in
that we push aside a little bit and we are not close to the aorta. That's very interesting. You see that?
Can we see the echo image? Can we see the echo image? Yeah. I think the wire position changed, Olaf, because the previous cross, definitely the wire was in the other part of the hole. And I saw that you lost wire position and you recrossed.
But
if the wire is soft enough and you push the wire, if it's in the big hole, it'll push up toward the retroaortic rim. If it won't, it's in the smaller hole.
Let's see when you try to inflate the balloon. If there is a waste there easily, then you are through a small hole. If there is no waste, then you are through the large hole.
But Siad, we all agree, a small hole, it wasn't a small hole, right? It was quite large.
That's right. But it kept getting larger as you had more volume in the balloon. Initially, you started with about maybe 12, 13 millimeter. By the end, the balloon was fully inflated.
Fine.
Yeah. So we try to bring up the balloon a little bit. And now it looks a little bit better in my eyes.
Yeah.
Right?
Yes, it looks better, and I'll see if...
the wire position is lost, but doesn't matter.
Now you're in the completely in the left atrium.
I retract a little bit. Can you balloon up? Use balloon here? That I hold it in place and you balloon it?
I think it's still posterior inferior
Here,
small
now.
hole.
Yeah. Yeah, because it's not sealing.
But what do you say about put color in? Now we have stop flow possibly.
No. There's flow coming across next to the aorta.
I think there's no question. There are two holes with a floppy septum in between. I think putting one device there, larger device, may take care of all of these two defects.
Yeah.
See the anterior, the shunt is still there.
The shunt's still there.
Yeah, Damien.
So give me one more time the multi-purpose. Get out there.
I was just wondering whether you might consider trying a wedge catheter, inflate the balloon while you're crossing and have a slightly stiffish wire in the center of it. It'll take you a little bit more anterior, and if you inflate the balloon, it might take you across the bigger hole or certainly prevent you from going across the smaller hole.
I don't think you're through a small hole. You've got the balloon up to about 20, 22
Look at on that now. Because now we
yeah.
are again not in the lung vein, and now it looks like we're in the right one, right?
I would try with a device in closest one.
Yeah.
I would choose a large device here and close this and see what happens with the residual shunt, because it seems that you cannot have a stable balloon position.
What was your maximum balloon size, Neil?
Balloon diameter?
Yeah.
Naji, do you have a comment? Go ahead.
I measured
yes,
18
I think it's
millimeters.
once we see that the two holes, sometimes more. So that two holes, I think the patient had more than two.
You have no recording of it?
It's possibility. So that
no.
It's very difficult to that two-dimensional variation.
Okay.
Sachin?
I think this is a more complex oval fossa defect. The thing which concerns me is the double layer which is seen on the right atrial side. You clearly see at the inferior end of the part of the septum, there's another small membrane going across, which actually is a flap of the oval fossa, which actually is covering it. And once you have that kind of an appearance, once you blow the balloon up, the soft flap can be completely pushed. If this is imaged with a 3D TEE, the complex nature of the ASD would be seen better. I do understand the advantages of trying to use ice here, but that double layer appearance which is seen in the right atrium is a marker that this is not a simple oval fossa defect.
Yeah, I agree. I don't understand completely the ASD fully. So give me the other wire first. So maybe we should try to look even without anything, or the majority is for a large device, and I think that's really the way to go, right? So let's
Olaf,
try.
personally, I would choose a device here about 20% larger than that diameter and deploy a device and then assess with color Doppler whether you have any residual shunt or not. So freeze that image there, please. And measure the largest diameter.
Can we
there.
Right.
$20
millimeters.
Right.
So I personally would propose for this patient to add maybe 25% and choose a device 25% larger than this diameter.
Can we measure on the fluoroscopy? And we do also, here. It might be 20, I agree. Also here. Can you hold the wire? Because otherwise it's diving in, that gives you a problem. Thanks. It's too far in, right? Now we do a last inflation. Here it looks really like two. Yeah, here it looks like, right? There's a second.
Can I make a comment here? I think there are two ways to approach this problem. The main problem, as I see, is that the superior anterior rim through which the wire is currently passing through is very floppy. So you're stretching that part of the septum and you're assessing a defect that appears to be smaller every time. You're getting the jet width on the color Doppler much smaller than what you're getting when you're not inflating the balloon. So I think there are two ways to approach it. Either you can go the way what Ziad suggested with a larger size, assuming it's a 20 millimeter waist, and because the defect is so close by, you can actually catch both of them together. Or you'll get a mushrooming effect if you deploy that, and you will realize that the PFO is not letting you actually push the septum as much as you want to cover the other defect, in which case I would like to consider the Amplatzer cribriform device.
No, the cribriform device will not work in this stream. No. Okay, go ahead.
You need a self-centering device.
Yeah. I would say we measured now 23 on the balloon, and we choose now the size of device, which could be either a 24 or 27. And I think maybe a 27 in that
27, yeah,
could be the right thing. So we will mount a 27 device and try if this fits here. It's a little bit challenging that we haven't fully understood what's about this ASD and anatomy, but it seems to be there are two. I agree. Okay.
My question is why not to use a more stiff wire to have a better stable position of the balloon. And a second point is,
are we a little bit cautious with that?
And if you
be a little bit cautious with the wire.
But if you gently push on a more stiff wire into the pulmonary vein, in general, you will have no problems. And second, this is a 3 centimeter balloon.
Yes, it is.
Because I'm not really convinced that there are really two defects. So we don't know really. And if you use then a larger balloon, a 4 centimeter balloon, you might have a better idea of the global shape of the ASD.
From your eyes,
you might be right. Let's see on.
From
here we
your
see the device we are going to use.
Yeah, your wire
the eyes
still
imaging.
What's posterior?
Oh.
So I'm afraid that you're undersizing.
We'll see. It could be. We had no real stop flow. We don't know if it's 1 or 2. The sizing balloon was not through a small hole because it was up to 22. If it's 2 holes, then the hole, what we have to cover, the whole thing is quite large, right? So we'll see. We use the Figulla Flex 2. Lars is preparing it here. It's coming with a biotome to hold it, which is quite nice. And it's loaded here, and now Lars will flush it. So it's loaded. So I take out that cheese.
Yep.
So you can see in the wire pass here, it's not superior. So it's most likely, as Chieling said, it's in the inferior posterior part of the septum. So now when he's going to put the sheath, most likely what will happen that there will be wasting on the waist of the device, but because of the nitinol property, it may open up and then cover the superior defect. But we'll see, obviously, once he does that. Brad?
Ziad, what you said, if you oversize the device and go through a larger hole, it's possible that you will cover the smaller hole. But if you go through a smaller hole, my concern is that there will be a mushrooming effect. And what you saw with the balloon, exactly the same thing you will see with the device. That's my concern.
I agree with you. I think I would have crossed the superior hole, put the device, the larger device in the superior hole, and see how it looks. You see how the sheath lies low in the septum, guys? Usually the superior anterior defect usually is the larger of the two.
It's not bleeding
and
back.
the posterior is usually smaller. In this case, just looking at the fluoroscopy and actually even the eyes, your sheath looks like it's in the inferior posterior defect, and that may not take care of the larger defects. But let them deploy it, and if it does not look good, they can recapture and start over.
Why didn't we just put in another wire through a second venous line now?
Yeah,
through the superior defect
position.
We dropped out. Give me again a wire through that one. We dropped out. We couldn't aspirate. We were against something when we crossed it. Oh, a stiffer wire. We couldn't aspirate when we crossed it, and it was not coming back, which is dangerous for air embolism. Can we aspirate?
Eric?
I need something with a lure lock.
I would just say that there's something to be said, like all the things we do, of having processes and ways of doing things, so we kind of are not, we kind of make the best decisions sequentially. Like, you don't skip the step in a pulmonary valve where you balloon size and make sure the coronaries aren't going to get occluded. And I think this case is a very good example of that. This case, you should have a wire across both defects. You should have a balloon in both defects. You should assess what you're going to do in what order. You should have a second wire there, so if you want to put something in the second hole, you can do it. And I think trying to rush for a live case for this patient is difficult.
Yeah.
Okay,
because
Olaf,
it's a lot,
Olaf,
and we are not really sure.
Okay, here what we're gonna do. We're gonna come off the camera. We're gonna leave you alone. Do the case right way, and then we'll come back live to you, and you show us the steps.
Great.
Okay, so we're gonna go to Rome now, and you work with Lars and try to cross the two defects and do a lot of cine images and echo, and we'll come back to you. Thank you. So let's go. Let's go to Rome.
I think it's a good idea.